Hello, everyone. My name is Mayssan Muftah. I'm an esophagologist at Brigham and Women's Hospital and Harvard Medical School with a clinical and research focus in eosinophilic esophagitis, or EOE. Thank you to GIE for allowing me to discuss our manuscript titled Yield of Esophageal Biopsy Patterns for the Diagnosis of Eosinophilic Esophagitis. Our goal for the study was to determine if standard biopsy practices for EOE diagnosis were adequate to capture all comers with EOE. Current consensus guidelines recommend obtaining 5 to 6 total biopsies from 2 esophageal segments, distal and either middle or proximal. While there's sufficient data to support the total number of biopsies needed, there's little data regarding which esophageal segments to get biopsies from each time. The focus of our study was to assess the rate of eosinophilia at different esophageal segments in patients with EOE, allowing us to evaluate assumptions supporting current recommendations. The first assumption is that biopsies at the distal esophageal segment have a yield of 100% for eosinophilia in patients with EOE. So distal esophageal biopsies should capture all EOE diagnoses. The second is that biopsies at the middle or proximal esophageal segments have a similar rate of eosinophilia. So biopsies at either one should have a similar diagnostic yield. In order to evaluate this, we used our institutional database of consecutive patients with newly diagnosed EOE at our 3 endoscopy sites. We included patients that had at least 2 esophageal segments biopsied. 511 patients were included over a 5-year study period. 451 had 2 esophageal segments biopsied, and 60 had 3 esophageal segments biopsied, with all patients in our cohort having biopsies of the distal esophagus. Notably, we found that the majority of patients, 56%, had at least 1 esophageal segment without eosinophilia. 10% of patients in our cohort did not have eosinophilia in the distal segment. This contradicts the assumption that all patients with EOE have eosinophilia in the distal esophagus. We also found that in patients that had both middle and proximal esophageal biopsies, the rates of eosinophilia were discordant 30% of the time, with eosinophilia being much more likely to be present in the middle rather than proximal esophagus. And lastly, in patients with 3 biopsy sites, about a third had eosinophilia isolated to only 1 esophageal segment. Based on our findings, we found that the current recommendations for biopsy practices to diagnose EOE are largely adequate with some modification. We suggest that biopsy should be obtained from the distal and middle esophagus every time because of the higher rate of eosinophilia in the middle esophagus compared to the proximal esophagus. This is more likely to ensure EOE diagnosis at the time of diagnostic EGD, which is particularly important in those that do not have distal eosinophilia. The clinical utility of obtaining proximal esophageal biopsies is unclear, although these can be considered to characterize disease extent and distribution. However, future studies are needed to determine if the distribution of eosinophilia and EOE has an impact on patient outcomes. Thank you again to GIE for allowing me to discuss our accepted manuscript. Please check out our paper for more details and feel free to reach out to me with any questions.